has been a member of ISQua for a long time now. Both of our speakers are ISQua Academy members and experts. So Elom is a national and international consultant on healthcare quality and patient safety. He's a conference speaker and a panel member on several quality and patient safety conferences, and he's currently the technical director and founder of the Africa Institute of Healthcare Quality, Safety and Accreditation. So in Ghana, Elom has played various roles, including supporting the development of the National Quality Strategy and the National Patient Safety Policy. He also contributed to the development of the Mother-Baby Friendly Health Facility Initiative training manual, which seeks to improve maternal and newborn outcomes. He is the QI manager of the Corlebu Teaching Hospital and was the national consultant on quality improvement for UNICEF. Now there's plenty more in Elom's bio that I'd probably be wasting time if I keep talking. So I'm going to move on to Gilbert Buckle. So Gilbert is the executive director of, is it ISQua? How do you pronounce the acronym? Yeah?
Yep, ISQua, spot on.
ISQua. He's a public health physician and consultant in health system strengthening and quality in healthcare. He's a member of the International Society of Quality in Healthcare and an elected inaugural and founding member of the Academy. Gilbert is a certified executive coach as well as an organizational development certified consultant. Nationally, in partnership with the Institute for Healthcare Improvement, he's been involved in the design of national level quality improvement interventions. Interventions and institutionalization of quality systems and practices within healthcare facilities. As a faculty for IHI, he has as well participated as the country lead facilitator in designing and delivering a high-level training for CEOs and heads of government agencies of the Ministry of Health in Ghana. So that's two very distinguished speakers. Thank you very much for being with us. I think Gilbert's going to speak first. So I'm going to hand over to you, Gilbert. I'm going to mute myself and stop my video. And if everyone else can do the same, that would be fantastic. Thank you.
Thank you very much. Thank you very much for that introduction. So I think you're all aware that this is being recorded, just to let everybody know that the session is being recorded for purposes of learning and sharing. We'll be presenting on the topic that we've advertised. I will start with the presentation and then my colleague Elom will continue halfway through it. We do have 3 polls, simple, interesting things we think, and hope that you will have fun. You will have fun in participating in the polls. So I am Gilbert, and when Elom comes up, he will also show his face, as it were, and we will take it from there. Okay, next slide, please, Elom. We'll give you a little bit of who we are as ISQua, a little background to the presentation. We'll also give you some reasons why we think another model works and should be in place. Then we'll discuss the model itself, give a few concluding remarks, and open up the floor for questions and discussions and any other insight people want. You may, in the process of the presentation, just put your questions in the chat. I am sure that Katrina will look at it and remind us at the end of the presentation. So we are a Pan-African Institute registered in Ghana, founded in Ghana and registered in Ghana, looking at quality and patient safety in the broad sense. We also offer accreditation support to health facilities that want to use accreditation as a tool for improvement. But we ourselves do not accredit. So we use the relevant standard JCI, COSASA, etc., and support facilities to achieve them if that is their wish. And we advise them as well on what to do. Our services. So this is our website. Our website, we look at all the various dimensions of quality and provide technical support, training, capacity building in that space. Next slide. Yeah. We first support accreditation. We currently have assignments we're doing. Those who've chosen to do JCIs, those who choose to do others, we go in, provide mentoring, coaching, help them design and put in place the necessary things they do. Consulting advisory services as well, and also capacity development for individuals as well as institutions. Next slide, please. Now, I didn't say this. I did not say this, but any intelligent fool can make things bigger, more complex, and more violent. but it takes a touch of genius and a lot of courage to move in the opposite direction. We think we all here are probably choristers in the same choir, singing on the same page, but quality has been defined variously, but more as the extent to which individual populations get closer to the kind of outcomes that they want. The care people receive is noted in lower middle income countries and those outside that is often inadequate and poor quality in many aspects of the services that are provided. And we also, the Director General of WHO has made it clear, without quality, the universal health coverage remains an empty promise. I mean, what are we actually trying to get if it's not what ought to be in the right way at the right place? And therefore, for us, the issue of quality on the continent where we focus is more about making sure that this happens. Why another quality model? There's the PDSA, there are many things. The Kaizen, there's the 7S, there are various different models used to approach quality. We posit that there's a need to have more systems thinking, systemic approaches to supporting the work and introduction of quality. And therefore, we seek to understand the connection among the different elements of the health system and how they work together to ensure that care outcomes are achieved they want. There's a lack of systems perspective that has created more problems for the continent than we would wish, though all well-intended. And the solutions to one of these problems has led to new and bigger problems, where we say that there is a fundamental system that is in place. And in systems thinking, we say a system is perfectly designed to deliver the results that we get. So if we're not actually achieving the kind of quality care outcomes we desire, it is not about the interventions in and of themselves, but it's about the design of the system that is expected to deliver those quality outcomes. There's a need to move away from events and patterns of behavior, which are symptoms of the problems, and get down to the fundamentals, which is how the system itself is designed and prepared to deliver quality care outcomes. And also, we also believe that we need to determine the most important place to intervene to ensure a long-term behavior change of the system. So it's not about solving the problems, it's not about solving the symptoms of the problem, but we believe you need to get to the fundamentals of the institution, of the health system, and make changes there to ensure that the kind of quality outcomes we want happens. Next slide, please. Yes. Most of the existing models have proven insufficient in addressing complexities in the African systems. So we have many interventions through very well experienced institutions. We come in, we try to make changes either in maternal mortality, in child health, in different aspects of care outcome. When these interventions are over, the system reverts back to what it was before. You give yourselves a couple of years and you wonder whether there was ever an intervention in that facility, in that health system, which led to improvements. So we are looking at issues of sustainability and issues of resilience in that space. Next slide, please. Good. What we have put together is not rocket science. What we have put together, which we call a model, is not necessarily an innovation or a primary change in and of itself. We recognize various bodies of knowledge, processes, and skill sets. And what we've done is brought all these together in an alignment to improve the effectiveness and efficiencies of what we do. It speaks to core issues of sustainability. It talks about readiness. You want to introduce quality improvement into an environment. It's important to understand, is the environment ready for it? And if it isn't, we also, in our experience, have realized that until the institution or the environment is ready, we might as well not even start. We believe that quality is the DNA of healthcare. We believe that the outcomes institutions should be striving, or countries should be striving to achieve, are outcomes which represent the dimensions of quality, from safety to timeliness, efficiency, effectiveness, patient-centeredness, equity, effectiveness, integration. These should be the indicators of these quality dimensions, should be the fundamentals to which all institutions and health systems strive. and everything else will fall into place. Okay, and it acknowledges the fact that improving quality of care will require a system-wide intervention. There will have to be a fundamental change to the architecture of a health system, whether we talk of a health system at a hospital facility level, a health system as a national geographical level, or even global levels. We need to be able to change fundamentally how the system is designed to provide care. Next slide, please. Good. It is premised that health systems have to be resilient towards sustaining the implementation of quality practices. We understand resilience to be having the ability, one, to be sensitive to changes and the ability to respond to changes. And therefore, applying the concept of resilience to quality at the facility level, we are saying that the facility must have mechanisms, processes, procedures, which allows it to recognize that there is a deviation from the desired quality of care. And at the same time, it must also have the capacity to respond to bring the institution back to producing the levels of quality that it desires. And this concept of resilience is being applied to the health systems and the different components of the health system, meaning that we talk of the WHO components of the health system: governance, human resources, infrastructure, health information, community participation. All these are the blocks upon which the health system functions to deliver the outputs and outcomes of quality. Next slide, please. Good. So the model is informed by literature, gray literature, and published, but a good amount of the thinking and the considerations made come from our own experiences in actually being on the ground, running quality programs, engaging with partners to implement quality programs, and what we have observed in the process. And put this together and said, you know what, we need to have a slightly different way of putting the pieces together and taking our time to implement or introduce quality into at the facility level and beyond. Next slide, please. Good. This is basically what the model looks like. It's an iterative process. We have leadership, commitment, and buy-in at the center, which holds all the other pieces of the model. There's a need for situation analysis of quality management capacity and quality of care. At the facility level, we need to know what is the current state of services and outcomes with respect to the quality dimensions. How safe is care? How timely, how effective, how efficient? You need to know that before we even decide where we want to intervene. And we are talking about a holistic assessment of all the dimensions and how they play out at the facility level. The next thing we want to do is find out system strengthening for quality management. So the second piece, number 2, is about the readiness of the institution. Where are the gaps? How sensitive is it to deviations in quality, and how responsive is it? And for each of the various system blocks, there are a minimum set of indicators that gives an idea of how the system is able to address and recognize deviations and what needs to be in place for it to be able to respond. The third part of the model talks about the system strengthening. Having now known what each system component is like, what needs to be done to improve its sensitivity, what needs to be done to improve its ability to respond. Having said that, now we are now interested in making sure that we develop these interventions using the PDCA models and other already existing models, but these are now done in the context with clarity of the situation of the entire facility and clarity on the gaps of the entire systems in the facility before interventions are designed. Experience has shown that you may go into an institution, engage to improve maternal health improves in quality, all other services are where they are, or even worse. When the intervention ends, there's chaos at the facility, and you ask yourself, was it worth entering to engage in that space? Were there not fundamental systemic concerns that should have been addressed to enable the facility accommodate the change we're looking for and also be able to replicate it in other areas of services. Good. We also realize the issue of standardizing accreditation. The whole essence of quality is to make sure that the intervention, the fidelity of the interventions are sustained over time. And we've also realized that with one-off projects, 2 years, 3 years intervening, it's only in one dimension of care, one area of care, and the entire facility does not actually have the capacity to institutionalize and maintain the skills and knowledge that is acquired. So that's another major component if you want to institutionalize and maintain the resilience of a health facility for quality. And like finally, you have the iterative process of monitoring, ensuring that the databases, the MIS systems actually do capture quality outcome indicators for purposes of being able to know where the deviations are and being able to determine what needs to be responded to and how. Okay, so I will now ask my colleague Elom to introduce himself again as well, and he will take us through these 6 circles of the model to give us a little bit more insight. Elom?
Yes, so thank you very much. So we continue. So when you, okay, so I think Katrina can do the second poll.
The first poll.
First poll, Elom, yeah?
Yeah, okay, poll, that's yes. Fine. Yeah, so you can do the first
poll. Yes, yes, yeah. The first poll.
Okay, I've just launched it there, so it should pop up on everyone's screens.
Yeah. So as colleagues, which of the following definitions of quality best resonates with you?
It's just choose one.
Interesting.
I think it's probably very hard to pick one, isn't it?
Yeah.
Yes.
So there should be 12 of you, 11 left. Just leave it for another minute or so.
Yeah.
Okay, I think these are interesting results and outputs, but we'll see. So I think basically we are looking at improving care outcomes and satisfying the needs of the patient as what is resonating most with us and what our best definition of quality looks like. But for us, we have seen in our work that the definition of quality becomes very subjective and depends on who you are speaking to. Even though we all agree that as practitioners and as providers, the outcomes of care are key as far as our practices are concerned. So I'm sure that is why a lot of us are looking at improving outcomes. But there was one time I was in one facility and we asked a midwife what quality meant to her. This was in a facility in one of the countries on the continent. And she indicated that for her, quality was, it was more how she would like to be treated when she was in the shoes of the patient. And that was very striking. It's like they do unto me what I would like to be done unto others, which was very striking. and it was quality more from the person-centered or the people-centered perspective than a clinical effectiveness perspective. But it is all good, so we keep and work with our definitions. So we have seen the model as has been explained or briefly talked about, that it's an iterative model. So if we look at leadership commitment, for us, what we are, our definition of leadership first has to do with top management. And in looking at leadership, oftentimes when we look at leadership, so again, another thing that comes to mind is that for leadership, we have the positional and functional leaders. So the positional leaders are those who have been appointed, elected, or nominated into various positions of power and authority, so that they are able to exercise some level of influence in the day-to-day administration of their organizations or of their departments. So that's the positional leader. And the functional leaders are sometimes you and I, even though I can't hazard a guess, but people like us who are not into any positions of power and authority, but are functioning and doing what we do just because we have to do what we do. Just because of our training. Most of us are doctors in clinical practice, nurses at the bedside, etc., without any form of positional role. So we are just members of staff in various organizations and various corporations or various healthcare facilities. So these are the functional leaders. But for the leadership commitment, I mean, we require the commitment of both. But most importantly, top management and the positional leaders. That is very key. And we'll be seeing why that is key, because I mean, they have the authority to command the release or otherwise of resources. So resources here being material, human, etc. So equipment and all the requisite resources that is needed to facilitate improvement and to facilitate improvement of outcomes. And we are also saying that the leadership commitment, or the step one, is not an event, it is a process. So if you look at the rings, you see that it is interconnected and interlinked across all the various nodes of the model. And so that is also very key. When you are doing situational analysis, you may have to go back, or you will even have to go back and then solicit and elicit commitments. At the point of systems thinking, you will have to go back and elicit commitment and buy-in. At every stage of the model, you will have to go back and then ensure that, I mean, you are carrying the system along, and you are carrying everyone along. And more importantly, you have the tacit and the explicit commitment and support of top leadership. That is very key. So we say that it's iterative, it is a never-ending process, and it permeates all the other components of the model. And I mean, for us, we believe that without leadership and without top management appreciation or understanding and commitment to an organizational culture towards quality, very little, or even in some cases, nothing can be achieved. If anything is achieved at all, whatever is achieved might not be sustainable. So that's the first. And then the situational analysis, we are also saying that so that is our step two. And for situational analysis, we are saying that the context in which quality is achieved is unique to each and every organization. So it is not a copy and paste, that something has worked in Chris Baragwani Hospital in South Africa, so it is going to work in Aga Khan Hospital in Kenya. It is not a one size fits all, or it has worked in Oladurin in Sierra Leone, so it's going to work. It's going to work in Liberia. It is not a one size fits all. So context is very key, and that is why we do the situational analysis, to enable us understand and for us to know the context within which quality is being implemented. And I mean, every good situational analysis is a very painful process, and it is a very, it demands a very meticulous step and process. You don't just in 1 day, 2 days, I mean, you quickly collect some data, speak to a few people, and then you think that you can make a determination of the state or the current state of the situation, and then go ahead to make prescriptions for improvement, which has been the attitude. And you are also interested in the capacity of the health facility to undertake quality management. So what is the capacity with respect to human resource, with respect to the with respect to your HMIS systems and all the other health systems building blocks? What is the state and your ability to perform the necessary functions that has to do with quality management? So your quality planning, your quality assurance, or your quality control, and then your quality improvement. So that is also very key. So at the end of the day, then you can make a determination as to whether the institution is quality ready or not. So that is very key. So that you need a very powerful situational analysis. And this is one situational analysis that was done in one country. This country has implemented quality for 5 years. And even after 5 years, look at the state of the state of affairs after 5 years of implementation of quality. And you could see that, I mean, there were so many barriers to the health system that was not taken into consideration 5 years ago. But probably we were in a hurry to deliver or to indicate that we also have a quality strategy or we have a quality program. So we are in a hurry to implement. We are in a hurry, one, to prescribe, and two, we are in a hurry to implement. So you see that after 5 years, I mean, all the health systems building blocks, look at the barriers to all the health system building blocks. And I mean, so the only place where there were enablers as far as the building block was concerned was partnership. And most of the times you see that partners are willing, partners are ready to push an agenda through. Sometimes countries are not ready, but I mean, countries flow with partners because, I mean, of whatever resource they are bringing, and they feel that, I mean, even though we are not ready, this resource can still be used to move some step further as far as our health system is concerned. So we push an agenda without effectively or appropriately addressing all the various components of the health system that can ensure sustainability of the quality program. And this is the sustainability analysis that we also did, also guided by the health system building blocks. And you see a sharp contrast from the first slide and the second slide. And you see partnership. You see that partnership has changed from blue to orange. And I mean, it tells us invariably most partners are not necessarily interested in sustainability and ensuring that the quality programs they are in a hurry to implement are sustained. And that is one big deal. And for we practitioners in lower middle income country, it will have to be a very important area of consideration in our quest to implement quality programs in our health systems and in our health facilities. So our ability to ensure that we adequately understand what the issues are and what the current situation of the country is, and to indicate and make a determination of the ability of the various components of the health system to support the implementation of any quality program that we seek to introduce as far as the national health system is concerned. For us, this is key, and we will have to appreciate and understand this. The other is the systems strengthening for quality management. So when we have understood the situation and how the various components of the building blocks are faring, then we move to strengthen the various components of the health system, which are the leadership and governance issues, ensuring that there are structures, there are policies, for quality as far as the country is concerned, issues of standards and care practices, and modeling a culture of quality. So that is key. And systems thinking is for us to also appreciate wholeness. We don't only think we are intervening in service delivery. We are in a hurry to reduce maternal mortality. How about the governance and leadership issues within the health system? How about the metrics and the measures within the health system? How about the human resource issues within the health system? So there will have to be a very comprehensive view and thinking of the health system in as much as we try to push the agenda forward. So the foundation of quality, we say, is a health system that is designed for quality, and also to ensure that we strengthen the health system components of the institution or the country to better manage and implement quality. And we say that working in health systems that are inefficient and irritating has a negative effect on one's ability to deliver quality care outcomes. So that is, a lot of healthcare workers are suffering from burnout, and one morbid condition to another, just because of how we are health facilities are designed for service delivery. And quality improvement interventions for care outcomes. Oftentimes, a lot of us intervene from here, and this is one of the easiest places to intervene, isn't it? We bring our PDSA, all the other models, and all the other QI tools, and then we are in a hurry to throw in one form of intervention or the other to reduce newborn care, to reduce maternal mortality, to reduce sickle cell prevalence, incidence, etc. We are always in a hurry to start from 4. But when the system is quality ready, quality improvement interventions are then initiated and executed to improve service and care outcomes. But when the system is not quality ready, you can do your intervention and plug in at 4. But I mean, after 4 years, after 1 year, after 2 years, after 5 years, there is no evidence of your intervention, of you intervening in the system. And fortunately, some of us have been working in health systems and health facilities where there have been interventions, some 5 years ago, some 10 years ago, even some before we were born. But as we work and we go around, there is no evidence of any quality intervention that has happened within those health systems or within those health facilities. And I mean, it becomes very fascinating, and we wonder what the agenda at the time was. So we should not be quick to plug in here without us sufficiently going through the mill. Otherwise, I mean, whatever we are doing will not be sustainable. Then after that, we go to the 5th stage we are calling standardization, accreditation, and certification, or what we are also referring to as institutionalization. At this stage, we are sure and we propose that there will have to be institutionalization of the practices, so that in step 4, you would have used your PDSA and all your other tools. And at step 5, we are sure that you should have learned from your PDSA, you should have known what works, what does not work, and what the probability of the outcomes are, so that you are able to adapt, adopt, or abandon all the necessary practices within your setting. And then you can standardize. Then you can opt for accreditation. Accreditation, our definition of accreditation is the ISQua definition or the FUSASA definition of accreditation, where you are inviting a third, and the reference is key because we have also worked in various countries and we see that there are very weird definitions of accreditation, and countries have their own coinage of what accreditation is. That's why the reference is key, that you have the confidence to invite an external third party to walk in with the necessary quality standards and then measure you, and then you are able to hold your heads up because your processes are very stringent and you are applying the necessary quality standards, you are applying the standards, and you are reaping the outcomes that you desire. So at this fifth stage, that is what you could be doing. And it's a form of validation of your own quality processes and of your own internal ways of doing things. It's a way of validation, and it's a way of getting others to also see what you are doing and to say that, I mean, we give you a thumbs up because you are doing what we are all doing, and we are doing what the standards say we should be doing. So that is very, very key. And in our part of the world, it takes facilities years for them to meet just one accreditation or one scope of an accreditation standard. I mean, and it tells us that oftentimes, and we struggle because the foundation and the building blocks are very weak, and we sidestep a lot of things, and we think that we can plug in and then we can attain the desired standards and outcomes that we want. But we will have to comprehensively engage and go through the entire mill if we want sustainability. And for us, the key is sustainability. And the final stage we are referring to is the iterative monitoring and evaluation of performance of your intervention. So you are looking at how you are faring. It's the ability of your health system to measure and report what is important to the people. And that is outcomes of care other than inputs. I mean, a lot of us, if I say as in LMICs, our measures and indicators are input oriented. So how many flower pots do you have? How many sphigs do you have? How many glucometers do you have? How many patients have you seen? I mean, we are very input and output oriented other than outcomes and process oriented. So that is key. So our HMISs will have to be making a shift from measuring inputs to measuring outcomes and processes. That is very key as part of the process. That is the only way we can make a determination of what is important to the people or what is important to our patients. So this is the summary of the model, that there is a need for us to get leadership commitment and buy-in, understand the situation, and then strengthen the building blocks of the health system sufficiently and adequately before we plug in our quality improvement interventions. And then we take a step further to ensure that we are institutionalizing quality, either through the use of standards and ensuring that we are adhering to the standards or accreditation and/or certification. And then we establish and put in place robust mechanisms to ensure that we are monitoring and evaluating the performance of every intervention that we have instituted. For us, we believe that some of the key success factors to the use of the model is the team cohesion, teamwork. I mean, wisdom is not in the head of just one person. So, and quality is also not a one-man show. So you need a team that is willing and ready to go to the mill and work together with you. It is also the individual and institution's capacity to innovate, because you require a lot of innovation. You have to think outside the box. And it's the institutional capacity also to initiate change and to adapt change, because we have to be willing that the status quo has to be moved, and the change we are talking about has to be transformational. And it also requires the intrinsic motivation of every healthcare provider within the institution, because if the top manager says go and the providers are reluctant, I mean, we are not going to get anywhere. And then the other is commitment to quality. We have to be committed to quality. And it's not only lip service. Oftentimes when leaders say we are interested in the process, it is often lip service, but we are not interested in lip service commitment, but a commitment that shows both intrinsically and extrinsically. And there will have to be involvement of all key stakeholders in the planning and the implementation of the activities, and then as far as going through the entire cycle is concerned. So that is very key. So these are our key success factors. So we conclude by saying that the model is iterative and responsive in determining the readiness and possible success of a health facility's quality readiness status. And we also say that it is an important addition and improvement of other models that are only quality improvement oriented without an appropriate consideration of very key and relevant health system factors that will ensure sustainable improvement efforts. So our watchword and our passion is sustainability. I mean, it is not enough to go and start an intervention when we will not see the fruits of the intervention after 5 years and after 10 years. Don't waste our time. Sustainability is key for us. So, I mean, we recommend and encourage colleagues on the call and elsewhere who will be watching the webinar later that, I mean, we can use this model in our context and our spaces to see how it fares, so that, I mean, it is part of the validation and the evaluation of the integrity and the utility of the model. But currently we are hesitant at generalization because, I mean, for every context it would have to be tweaked, because we ourselves acknowledge that no two contexts are the same. So I think we'll say a thank you here, and then maybe you can give us the third
poll.
The third poll, yeah, let's do the third poll.
Perfect.
And then and then we can take some questions.
Yeah. No, that's fantastic. I just wanted to ask real quick, Elom, how often would you repeat the cycle?
How often
would you repeat the model, repeat the cycle?
I mean, so it is iterative. So there is no way you will say that you have ended.
Yes.
Yeah.
Yeah, there is no, so because at every party, because I mean, for the situational analysis I showed, I mean, this country waited for 5 years for us to see some of the barriers we are seeing, and for us to see why the stated quality objectives in their quality strategy never saw the light of day. So it is an iterative process, and for us, it is a never-ending process as far as the model is concerned.
Yeah.
Over.
Brilliant. Yeah, we have a couple of questions in the chat, and if anybody wants to put their hands up as well, we can unmute you if you wanted to speak. We have about 10 minutes left. Yeah, so I'll just invite people to either put their questions into the chat or you can put your hand up.
Okay, so there's I'll take the questions in the chat and Elom will support. So one question was, what is the best way to get leadership buy-in? Provide training so they feel comfortable to oversee quality in all their activities. The best way to secure leadership buy-in is to put the KPIs of quality, to put the outcomes of quality in their KPIs. Most leadership have got KPIs which do not reflect any aspect of quality in and of itself. So if we're talking of 6 dimensions of quality, then the desired outcome of safety, effectiveness, efficiency, timeliness should be on leadership's KPI. The head of surgery should have which are based on quality outcomes. The CEO's KPIs should be based on quality outcomes. Operationally, what we have realized is that leaders will say, well, I'm not measured by this, I'm not assessed by this. My job is to make sure that I make this amount of money or I have these number of patients. But can you imagine if the head of surgery is answerable to the client satisfaction score of patients they see? Can you imagine if the CEO is answerable to the safety of patients who that institution sees? Then it becomes, then they were motivated, and then they actually will put quality and quality outcomes on their radar. In terms of tools, so we ourselves have developed a health systems health systems quality assessment tool, which has indicators or measures of responsiveness and sensitivity that one can use to assess the facility. And this is a work in progress. We also have developed strategic planning templates, which ask the relevant questions to inform the kind of intervention design that you want to do. So there are some tools. Some of the regular tools still work, Fishbone, but why? But all these have been put together in a way that allows us to assess the system within which quality will be done. So some of these are work in progress, and the others, of them so that are available will work. But we have developed a health systems quality assessment tool to decide, is the system component ready and sensitive to quality issues? And we've also put in place some templates that we developed to enable you to ask the right questions so that your intervention is designed to, one, improve the system as necessary, and two, help you achieve the kind of results that you want. Okay. I would like to ask about improving management. Thank you. I would like to ask about improving management systems. Again, so you want to improve the management system for a purpose. The best way is to have clarity of the outcomes the system wants to provide. So most of us will go, oh, we need to improve the financial management system in and of itself, or we need to improve the patient system in and of itself. No, the institution must have a clear set of outcomes that you want it to achieve. And if it is for the quality dimensions and clear outcome indicators, it is only then you are able to design appropriate interventions. And some of them are cross-cutting, some of them, so let me give you an example. So here we are in an institution, they've sent individuals out to train in vascular surgery, individual comes back, the theaters are not capable of providing the equipment for vascular surgery, there are no supporting staff who have the capacity to do vascular surgery. So it begs the question, why did we send somebody out to go and be a vascular surgeon? And that is normally the singular approaches we use. But you realize that no, there's an infrastructure requirement, there's an equipment requirement, because the outcome is not about a vascular surgeon. The outcome are clients who come with a need for vascular surgery get complete care in timely, satisfactory, efficient manners. We have institutions who've set up dialysis units, but logically you would want to go to transplant. Yet the laboratory was not involved in the planning. There's nobody who can do the surgery. So you ask yourself, how holistic and systematic did we approach this to make sure what is the outcome we want? We wanted the outcome is a patient who has access to the complete cycle of services. And even if we don't have it, you also need to look at partnerships and other parts of the institutional systems for these things to happen. Yes, so the health system assessment tool is a work in progress. We intend to finish that and share it as part of the discussions, hopefully at the Brisbane conference, and then we'll then put it out in the public domain.
Great, thank you very much, Gilbert. I don't know there if you saw the results for the poll for question 3.
Wow.
So
Yes,
which of the components of the quality model resonates best with you?
Yeah, I mean, I think it's interesting what the responses are. That it's also cutting across, and it's also telling us what as colleagues we are thinking and looking at as far as the quality process is concerned. Issues of leadership, and then the iterative monitoring, which are scoring 26% each. So I mean, I think it gets interesting. Let's get to use the model as a complement to what we have, and let's see what outcomes we both get in our health systems. But we are certain that this is the way to go, and it will ensure sustainability as far as every quality improvement effort in lower middle income countries are concerned. I mean, the countries we have worked in are LMICs and basically African countries, so we cannot speak for high income countries. So over. I see a hand, God's will. So Katrina.
Okay, thank you very much, Elom. This is a very interesting presentation, and I really want to commend your team for coming up with this model that puts leadership at the center of quality in healthcare. But I want to also look at factors that could influence these leaders to begin to think or pay attention to quality. Factors like the demand for quality by patients, by payers, or by regulatory bodies, and even the frontline providers. Because in my observation, these are clearly lacking in our setting. And of course, we know that I'm from Nigeria. There is no public reporting of quality indicators. So there's no pressure on these leaders.
What is it?
When you come to maybe an acute health setting, maybe where I work, you see that these leaders, they are only interested in patients. You come to the hospital, you see a doctor, you pay the bills. They are all, that is their primary focus. So, and the people are not also used to quality. So they don't even know what quality is all about. So you see, we have this vicious cycle of people just going to seek care, get whatever they want, and then they get out of it. Even the providers themselves, I'm talking about the clinicians who see patients. They come to the hospital, they sit down, see their patient, out the patient, and go. The next day they come, do their ward round, see patient. So this quality consciousness is not there. So I'm looking at your model as a very good model, but I'm also thinking that you should consider this other aspect, that we put pressure on these leaders to begin to think quality. The ones I just mentioned: patients demanding for quality, payers demanding for quality, regulatory bodies coming up as well, and even the frontline provider, I mean the clinicians, insisting that their clients must have good quality care. That's also what is running in my head now. Thank you, and over.
Yeah, God's will. What you are saying is the primary reason for our passion. Now, imagine if the doctor in the consulting room, when every patient leaves, they are either going to click a smiling face as satisfied or a sad face as dissatisfied, and that is what he is measured by. We will be mindful of how we engage. If the CEO is measured by the client satisfaction of the institution, they will want to collect that data and make sure it is at the level they want, and they will by default have to investigate the causes of their scores. The only way is to shift from output metrics, number of patients seen, number of the numbers, and look at outcome measures. It is until we make outcome measures the driving force of care, we will always be counting. I did 50 surgeries. We're not interested in 50 surgeries. We're interested in how many surgeries came out with no infection, no complication. We are interested.
Yeah, so let me, Gilbert is off. So it is more of outcomes and emphasizing outcomes other than the outputs that we have become very excited about. So that is very key. And for my colleagues, so in the leadership and governance, implicit in the leadership and governance are issues of regulation as well. Because I mean, the regulatory mechanisms and the regulatory practices within our context are the external factors that would push our leaders to ensure that they are doing right and they are uptaking quality. But I mean, I work in some countries, and healthcare providers are not, there is no form of licensing. So people are working for 2 years, for 5 years, and they have not renewed their licenses, and they are practicing. There has not been any form of continuing CMEs, continuing medical education or CPD programs, and they are practicing. So question is, how are you updating your knowledge when it comes to their practice? So when we discuss issues of the leadership and governance, implicit in leadership and governance are the regulatory systems and the regulatory structures that would compel and serve as the external stimulus or stimuli to the positional leaders to ensure that they are uptaking quality. Because I was saying that in our countries, facilities struggle whenever they want to take up any international accreditation. I mean, COSASA accreditation, QAI accreditation, ISO accreditation, or ISQua. I mean, recently we are supporting one facility in its ISO process, medical laboratory, and they started 10 years ago. And this is a public facility. It's another private facility that started its JCI accreditation journey about 5 years ago. So it tells you the weaknesses within the countries when it comes to issues of leadership, and more importantly, or equal to the regulatory mechanisms that we have, and what kinds of standards health facilities are working and striving to meet as far as their practices are concerned. I mean, so that's why we think that there will have to be a shift towards outcomes. And like Gilbert is saying, if you put an outcome measure as a KPI for a minister of health or of a CEO of a health facility, I mean, a lot of people will not even be clamoring for those positions, because they will know that it is work, that in 5 years, you have to improve or increase your institutional patient satisfaction by 20%. In 5 years, reduce maternal mortality by 10%. In 5 years, reduce your institutional neonatal mortality by 10%. And let's see how many people will be running towards such a position, knowing the kinds of responsibilities and the demands that are required to meet these KPIs. So, I mean, until there is that shift, unfortunately, we may remain in the status quo for a long time, and we will be playing into the hands of partners who have very genuine hearts and intent, who are willing to support us. But I mean, our health systems are unfortunately not ready to receive those supports, and their monies cannot wait. So they will plug in wherever they have to plug in as far as the health system is concerned, and then spend their money and go. And in 2 years and in 5 years, you are back to square zero. And so I think, like you said, it is a vicious cycle, but it has to be broken somewhere. And Gilbert, you are back, so over to you.
Yes. I know we are ending. I just want to share one conceptual framework we are developing to support this. We think there are 3 core pillars of intervention for sustainability and integration. One, we need leadership accountability. That is where we put this on their KPIs and regulatory bodies to make sure that these are the things that they're going to look out for. Leadership accountability. The second thing is we need workforce empowerment. People need to be trained in quality. Quality should be taught in pre-service. There must be courses for quality so people to understand it. There must be grades and categories, professional careers in quality to support this. And the third one is the people empowerment. We need to be able to make sure that we allow our clients to tell us what their issues are, not take offense, and use that feedback to further improve the system. So we need, and these must be happening simultaneously. We need leadership accountability. We need health workforce capacity. And we also then need the client empowerment to come and speak to and talk about these issues. If these 3 are happening, so we have countries where fine, most countries don't have leadership accountability and quality. No leader is being asked to account for quality dimensions, and that's a big issue. Few have got regulatory mechanisms in place. Few have got regulatory authorities to support it. But in our context, public empowerment is virtually zero. How dare you complain? And we take it as complaints. That's the word we use, not feedback. So the issue of community empowerment is virtually zero. Regulation is minimal, and leadership leadership accountability is nothing to write home about. But these three pillars must be intervened on at the same time. We are still thinking through and working on how this may be another session, a presentation down the line, but this is another observation we have made. Okay.
Thank you very much, Gilbert. I just noticed there a few people coming in. I think people might have got the wrong hour, but don't worry, because we've actually recorded this, and
Great.
We're going to send the recording around for anybody who might have missed the most of it. I just had a really quick question, if it's okay. I know we're over time, but do you see a future for value-based healthcare? You know, do you think that this model would fit in there?
Yes, I mean, so that's excellent. And definitely, Katrina, definitely. So it fits because one is two key areas, or even three, is the bit of the leadership commitment. So in our setting, it's a big deal where the people are not empowered. People don't even understand and know what value-based care is. So we reduce it to person-centered care, which is also key. So yes, this addresses all the quality dimensions as far as quality is concerned, and the bit of the leadership commitment and the systems strengthening. Because like Gilbert is identifying the three things, and the last one, which has to do with the empowerment of the people. That is very, I mean, I visit one facility, and this mother has lost a baby, and she lost the baby because of our negligence and because of our doing. But healthcare provider comes and says, oh, you don't worry, God will give you another child, bye-bye.
Yeah.
And there is very little empathy, there is very little appreciation of our own contribution to the problem, only to say bye-bye and to tell the woman that God will give you another one. And so we feel that, I mean, this provides an answer, and it addresses the key components of quality, because for us, the outcomes of quality are very important as far as the quality process is concerned. And person-centered care is very key as far as the outcomes of quality is concerned. And value-based care for us is a centerpiece to person-centered care, which cuts across all the quality dimensions. So we think that, I mean, the model is very forward-looking, and it addresses and ensures that, I mean, we see sustained improvement in our outcomes of care.